Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 292 of our pharmacotherapy series, which majors in heart failure. The first question applies to patient JAJ in part 291 of the pharmacotherapy series. Bed rest and a 3-gram sodium diet were ordered. The medical team decides to begin furosemide for JAJ. What is the rationale for using diuretics, and what route, dose, and dosing schedule should be used? Excessive volume increases the workload of a compromised heart, and diuretics are an integral part of therapy. This is especially true if volume overload is symptomatic, manifesting as dyspnea, as it is in JAJ's case. Diuretics produce rapid symptomatic improvement. They relieve pulmonary and peripheral edema within hours, whereas the effects of ACE inhibitors, beta blockers, and digoxin take days to months to be fully realized. Diuretics, however, should not be used alone. Even when they are initially successful in controlling symptoms and reducing edema, they are ineffective in maintaining clinical stability for long periods without the addition of other drugs. More importantly, activation of the renin-angiotensin-aldosterone system, abbreviated as RAAS, and sympathetic nervous system in response to diuresis could lead to heart failure progression. All current guidelines recommend diuretic therapy, both acutely and chronically, if clinical volume overload is evident, but further state that patients without edema can be treated either intermittently or without diuretics. Diuretics used on an intermittent, that is as needed, basis are titrated based on changes in weight gain, neck vein distension, peripheral edema, or shortness of breath. Patients with a good understanding of the disease can be instructed to weigh themselves daily and start taking the diuretic if they gain more than 1 to 2 pounds in one day or 5 pounds in 1 week, or have leg or abdominal swelling. Diuretics can be withheld as long as patients are at their target dry weight. In other cases, diuretic-free intervals or weekends can be arranged. Even with these options, if the patient has experienced volume overload at some time during the course of his or her disease, either past or present, a diuretic should always be readily available. Despite remarkable initial benefits, vigorous diuretic therapy carries the risk of volume depletion, electrolyte abnormalities, and diminished cardiac output. Abrupt worsening of renal function, increased BUN or serum creatinine, or hypotension indicates the need to temporarily withhold diuretics. We will now discuss the route of diuretic administration. Furosemide is a commonly used loop diuretic because of clinical experience and low cost. Bumetanide and torsemide are preferred in some settings because of more predictable absorption. Etoacrynic acid, which is also a loop diuretic, is not preferred because of its ototoxic potential. However, unlike other loop diuretics, etoacrynic acid does not contain a sulfonamide moiety, and it is mainly reserved for patients with severe sulfonamide allergies to other loop diuretics. According to one group of investigators, patients with heart failure treated with torsemide fare better than those receiving furosemide. During a one-year open-label trial, patients receiving torsemide were less likely to be admitted to the hospital for heart failure, 17% torsemide versus 32% furosemide. Admissions for all cardiovascular causes were also lower among patients taking torsemide, 44%, than patients taking furosemide, 59%. Fatigue scores improved to a greater extent in patients treated with torsemide, but no difference was found in the dyspnea score. Torsemide is more expensive than furosemide, and this may be an issue for some patients. Erratic responses to furosemide are prevalent in persons with severe heart failure or diminished renal function. Some patients respond promptly and vigorously to small oral doses of furosemide, whereas others require large IV doses to achieve only minimal diuresis. Part of these differences can be explained by the drug's pharmacokinetics. Loop diuretics are highly protein-bound and have to be actively secreted into the proximal tubular lumen to elicit a response. Tubular secretion of loop diuretics can be compromised in the presence of increased levels of endogenous organic acids due to renal insufficiency and drugs, such as NSAIDs, that are competing for the same transporters. Also, oral absorption of furosemide is erratic and incomplete, averaging 50% to 60% in healthy subjects and 45% in those with renal failure. When taken with a meal, absorption is delayed, but the total amount absorbed does not differ. There are claims that the absorption and, therefore, effectiveness of furosemide are further diminished in patients with heart failure attributable to edema of the bowel and decreased splanchnic blood flow. This has been partially refuted by one investigator, who noted an average furosemide bioavailability of 61% in patients with heart failure, the same as in normal patients. Total absorption in patients with heart failure varies widely, 34% to 80%. However, both the rate of absorption and the time to peak urinary excretion are delayed for furosemide and bumetanide. The rate and extent of absorption are not only different among individuals, but intra-individual variability also exists. Ingestion of the same brand of furosemide by the same individual on multiple occasions can show up to a threefold difference in bioavailability. These differences are evident with the innovators' brands such as Lasix or generic brands. Next we will consider dosing. Typically, a patient's treatment is initiated with 20 to 40 mg of oral or IV furosemide given as a single dose and monitored for responsiveness. If the desired diuresis is not obtained, the dose can be increased in 40 to 80 mg increments to a total daily dose of 160 to 240 mg, usually divided into 2 or 3 doses. For torsemide, a usual starting dose is 10 to 20 mg per day, but a ceiling effect is noted in patients with heart failure at a dosage of 100 to 200 mg per day. Equivalent doses of bumetanide are 0.5 to 1.0 mg once or twice daily, titrated to a maximum of 10 mg daily. Because JAJ is not in acute distress, it could be argued that oral therapy would suffice. The decision, however, is to give a single 40 mg IV dose of furosemide for immediate symptom control. Further increases in the dose or frequency, i.e., twice-daily dosing, of diuretic administration may be required to maintain an active diuresis and sustain weight loss. Another alternative in hospitalized patients is to administer loop diuretics via continuous infusion. Multiple studies have demonstrated the benefits of continuous infusions compared with intermittent infusions. However, the results of these studies have been questioned because of a lack of methodological rigor, and the studies have been underpowered to address the primary endpoints. Recently, the DOSE trial, an abbreviation of Diuretic Optimization Strategies Evaluation, showed no difference in efficacy or safety between intermittent IV bolus or continuous infusion. There are potential benefits of continuous infusion when compared with intermittent bolus dosing. Bolus diuretic dosing can cause a higher rate of diuretic resistance owing to the post-diuretic phenomenon. Continuous IV infusion results in a constant delivery to the tubule, potentially reducing this phenomenon. Additionally, continuous infusions are also associated with a lower incidence of ototoxicity owing to lower peak concentrations. Patients who are candidates for continuous IV infusion should receive a loading dose before infusion to reach steady-state concentrations faster. However, if the patient has received one or more IV boluses within the previous few hours, then an infusion can be started without a loading dose. In case of inadequate response, the loading dose should be repeated and the infusion rate increased. The infusion rate depends on the patient's renal function and response. The next question reads, examine JAJ's laboratory values in the earlier slides. Does JAJ have any abnormal values? What is the significance of these abnormalities? We will first of all consider azotemia. JAJ has an elevated BUN of 40 mg per deciliter, but a normal serum creatinine of 0.8 mg per deciliter. Worsening renal function is characterized by an elevation of BUN and creatinine. A disproportionately elevated BUN relative to creatinine is indicative of prerenal azotemia, secondary to poor renal perfusion from heart failure or overdiuresis. Serum creatinine will also rise in some patients with prerenal azotemia, but will quickly return to normal with rehydration. JAJ's laboratory values reflect prerenal azotemia. The most probable cause of his azotemia is decreased renal blood flow secondary to decompensated heart failure. Diuretics should not be withheld and, in fact, judicious diuresis should improve his heart failure and help lower his BUN. Caution must be exercised because excessive diuresis and volume depletion can cause renal ischemia, leading to true renal damage. If this happens, the serum creatinine also will rise. Regarding hyponatremia, a low serum sodium of 132 milliequivalents per liter is noted. Low serum sodium, however, is not necessarily a sign of overdiuresis. A person may be significantly overdiuresed with a body deficit of sodium, but if that sodium is lost isotonically, the serum sodium concentration will be normal. Conversely, a person such as JAJ can be hypovolemic, indicating excessive body sodium, but the serum sodium concentration may be normal or even low. Hyponatremia, low serum sodium concentration, reflects the dilutional effect of extra free water in the plasma. The most common causes of dilutional hyponatremia are excess antidiuretic hormone production or excessive free water intake. Individuals on severely sodium-restricted diets can experience hyponatremia. Likewise, patients given too much diuretic and who are then given salt-free fluids or who have compensatory antidiuretic hormone release can become hyponatremic. Patients with heart failure or hepatic cirrhosis are more likely to develop diuretic-induced dilutional hyponatremia because of pre-existing defects in free water excretion. The exact cause of hyponatremia in JAJ is unknown, but his marginally low serum sodium does not contraindicate continued diuretic therapy. In general, levels of serum sodium concentration less than 120 to 125 milliequivalents per liter are associated with adverse events in heart failure patients. Chronic serum sodium concentrations of 130 milliequivalents per liter or less are associated with higher morbidity and mortality. Asymptomatic hyponatremia can be treated with water restriction. In the setting of volume depletion, IV administration of normal saline may be effective. Vasopressin receptor antagonists can be used in patients with heart failure and hypovolemic hyponatremia. We will move on to hyperkalemia. JAJ has a serum potassium of 3.2 milliequivalents per liter. Hyperkalemia is associated with an increased incidence of arrhythmias. Some studies showed increased ectopic activity with serum levels between 3 and 3.5 milliequivalents per liter. It is estimated that the risk of arrhythmias increases by 27% with each 0.5 milliequivalents per liter reduction in the plasma potassium concentration less than 3 milliequivalents per liter. In chronic heart failure, potassium abnormalities are commonly seen. The risk of sickle cell disease in patients with heart failure may be lessened by using low doses of diuretics in combination with potassium-sparing agents, with the goal of maintaining serum potassium levels between 4.5 and 5 milliequivalents per liter. JAJ will be receiving increased doses of diuretics for the next several days and, therefore, may need additional potassium supplementation to prevent life-threatening hyperkalemia. In addition, if he needs digoxin therapy in the future, low serum potassium levels can predispose him to digitalis toxicity. Potassium replacement is warranted for JAJ at this time. Long-term potassium supplementation may not be necessary with concomitant administration of ACE inhibitors. If hyperkalemia persists, JAJ can be started on an aldosterone antagonist. Regarding hypomagnesemia, JAJ's serum magnesium level is 1.5 milliequivalents per liter. Severe hypomagnesemia can lead to somnolence, muscle spasms, a decreased seizure threshold, and cardiac arrhythmias, effects similar to those seen with hyperkalemia. Some investigators have claimed that many of the arrhythmias previously ascribed to diuretic-induced hyperkalemia were actually caused by diuretic-induced hypomagnesemia. Concurrent hyperkalemia and hypomagnesemia can be especially dangerous. JAJ should be given 1 gram of magnesium sulfate IV and observed for changes in his magnesium level. If needed, he could be given chronic oral supplements of magnesium. We will now discuss hyperuricemia. Increases of 1 to 2 mg per deciliter in uric acid levels are common during thiazide administration. Rarely, 4 to 5 mg per deciliter elevations have been reported. JAJ's uric acid level is 8 mg per deciliter, which is slightly elevated. It has been proposed that serum uric acid levels may be a valuable prognostic marker in heart failure patients. One study indicates a graded relationship between serum uric acid and heart failure survival. In heart failure, xanthine oxidase is upregulated, which can lead to endothelial dysfunction. Therefore, treatment with allopurinol may improve endothelial function and promote reverse remodeling. The relationship between serum uric acid and cardiovascular disease is still controversial, and the guidelines do not recommend the use of xanthine oxidase inhibitors to prevent cardiovascular disease. In patients who experience symptomatic hyperuricemia, the addition of allopurinol or other urate-lowering agent should be considered. Next we will discuss B-type, natriuretic peptide, abbreviated as BNP. JAJ's B-type natriuretic peptide is elevated, that is 1,365 picograms per milliliter. Various studies evaluating the diagnostic accuracy of B-type natriuretic peptide and NT-proBNP have used different lower limits to define normal values. The most commonly used plasma concentration to define the upper limit of normal for B-type natriuretic peptide is 100 picograms per milliliter, with concentrations greater than 400 picograms per milliliter being considered a strong indicator of heart failure. The age-related NT-proBNP diagnostic upper limit of normal is 125 picograms per milliliter for patients younger than 75 years, and 450 picograms per milliliter for patients older than 75 years of age. If the patient has a level below the upper limit of normal for the respective assay used, then the symptoms are most likely attributable to causes other than heart failure. In patients with renal impairment, the clearance of these peptides is reduced, therefore, the upper limit of normal is 200 picograms per milliliter for B-type natriuretic peptide and the corresponding value for NT-proBNP is 1200 picograms per milliliter. Moreover, concentrations of these biomarkers are influenced by age, sex, obesity, and other cardiac and non-cardiac comorbidities. Asymptomatic patients with heart failure can also present with elevated B-type natriuretic peptide or NT-proBNP levels. This confounds the accurate interpretation of these markers and makes it challenging to integrate their usefulness into routine clinical practice. Elevated B-type natriuretic peptide and NT-proBNP have an established utility in ruling out heart failure in patients who present to the emergency department with shortness of breath. According to the ACEI guidelines, measurement of B-type natriuretic peptide or NT-proBNP is useful for establishing prognosis or disease severity in chronic heart failure. However, the role of these biomarkers in reducing morbidity or mortality in heart failure is not well established. Several BNP-guided therapy trials have been published. The B-type natriuretic peptide or NT-proBNP-guided heart failure therapy can be useful to achieve guideline-directed medical therapy abbreviated as GDMT in selected clinically stable patients, but it is unclear if such an approach improves outcome. The guiding evidence-based therapy using biomarker-intensified treatment abbreviated as GUIDED study designed to assess the effects of NP-guided therapy in high-risk patients with left ventricular systolic dysfunction did not improve clinical outcomes between biomarker-guided treatment strategy versus usual care. It is still not clear when to use biomarkers to adjust heart failure medications. B-type natriuretic peptide levels may be elevated in patients receiving angiotensin receptor neprilysin inhibitor abbreviated as ARNI, as B-type natriuretic peptide is a substrate for neprilysin. Therefore, the 2017 update states that the utility of natriuretic peptide biomarker levels should be cautiously interpreted in patients on angiotensin receptor neprilysin inhibitor. JAJ's elevated B-type natriuretic peptide level, along with his clinical presentation, is indicative of heart failure exacerbation. The next question reads, the physician gave JAJ 1 gram dose of magnesium sulfate and 3 20 milliequivalent doses of potassium chloride IV. This raised his serum magnesium to 2.0 milliequivalents per liter and his potassium to 3.9 milliequivalents per liter. Should he receive prophylactic magnesium or potassium supplementation? What is an appropriate dose? At this time JAJ does not need further magnesium replacement, but his serum magnesium level should be measured again after he has received furosemide for a few days. If the level drops again, maintenance therapy with oral magnesium oxide tablets can be started. A fall in serum potassium concentration can be seen within hours of the first dose of a diuretic, and the maximal fall usually is reached by the end of the first week of treatment. Potassium supplementation is not required in all patients receiving diuretics. They should be monitored frequently in the first few months of diuretic therapy to determine their potassium requirements. Similarly, when diuretics are stopped, it can take several weeks for serum potassium to return to baseline. Therefore, it is possible that JAJ's admitting potassium level of 3.2 milliequivalents per liter reflects the nadir of his response to hydrochlorothiazide. His initial response to potassium supplementation shows that his hyperkalemia will be easily controlled. It might be argued that he should be observed for a few days and not given further supplements, however, because his diuresis is to be increased and if digoxin may later be considered, potassium supplementation is warranted. Long-term potassium supplementation may not be necessary with concomitant administration of ACE inhibitors and aldosterone antagonists. Because JAJ is started on furosemide, hydrochlorothiazide should be discontinued. If hyperkalemia persists, the aldosterone antagonist dose can be uptitrated. Next we will look at dose requirements. It is difficult to predict the dose of potassium chloride that will be required to maintain proper potassium balance. Many patients do well with 20 milliequivalents per day, but it is questionable how many patients need any supplement at all. People with well-documented hyperkalemia can require anywhere from 20 to 120 milliequivalents of potassium chloride per day. Those patients with disease states associated with high circulating aldosterone levels require doses of potassium in excess of 60 milliequivalents per day. In patients who need long-term potassium supplementation, efforts should be made to increase doses of ACE inhibitors to target doses or maximal tolerated doses, and appropriate addition of an aldosterone antagonist should be considered. However, a few selected patients may still need to take potassium supplementation, despite the addition of an aldosterone antagonist. The next question reads, after a single 40 mg IV dose of furosemide, JAJ is begun on 40 mg of furosemide each morning and potassium chloride tablets 20 milliequivalents twice daily. How should his therapy be monitored? JAJ needs to be monitored for both an improvement in his heart failure and for side effects. Subjectively, the clinician should monitor for decreased pulmonary distress and an increased exercise tolerance, demonstrating control of heart failure. Objective monitoring parameters for disease control include weight loss ideal 0.5 to 1 kg per day until ideal dry weight is achieved, a decrease in edema, flattening of neck veins, and disappearance of the S3 gallop and rails. Because JAJ has hypertension, his BP also requires monitoring with a goal to reduce it to below 130 systolic 80 diastolic. Patients are instructed to record their weight each day and are allowed to adjust the diuretic dose based on changes observed. If they are at their ideal dry weight, they may reduce the dose of diuretic by 50% or even hold one or more doses. If weight increases more than 1 or 2 pounds in a day or 5 pounds per week, edema increases, or shortness of breath returns, the dose of diuretic is temporarily increased. Dizziness and weakness are subjective indices of volume depletion, hypotension, or potassium loss. Muscle cramps and abdominal pain could indicate rapid changes in electrolyte balance. Objectively, a lowering of BP, especially on standing, and a rising BUN, that is prerenal azotemia, signify overdiuresis. Serum sodium, potassium, and uric acid should be monitored routinely. Questioning the patient with regard to the onset of diuresis relative to drug ingestion, and the duration of the diuretic effect helps develop the most convenient and effective schedule for the patient. The next question reads, if JAJ's furosemide dose was increased to 80 mg twice a day without much response, what should be the next step? All loop and thiazide diuretics must reach the tubular lumen to be effective. Because these drugs are highly bound to serum proteins and endogenous organic acids, they cannot enter the tubular lumen by glomerular filtration. For diuresis to begin, they must be transported into the proximal tubule by active secretion from the blood into the tubule. If this active transport is blocked, diuretics will not reach their site of action. This can lead to a diminished diuretic response in patients with either renal insufficiency or decreased renal blood flow associated with decompensated heart failure. Patients with renal insufficiency or poor renal blood flow often require large doses of diuretics to achieve a desired response. Endogenous organic acids can accumulate during renal insufficiency, avidly binding the drug and preventing its access to the site of action. Both the total amount of drug delivered to the tubule and the rate of delivery of the drug to the tubule determine the magnitude of diuretic response elicited. This explains why 80 mg of furosemide yields more diuresis than a 40 mg dose and why an IV injection provides a more rapid and vigorous diuresis than an oral dose. Once a threshold concentration, that is the ceiling dose, is achieved within the tubule, higher concentrations produce no greater intensity of effect, but the duration of action may be prolonged. Many patients exhibit a blunted diuretic response with continued therapy for unknown reasons. Continuous infusions of furosemide 5 to 15 mg per hour, bumetanide 0.5 to 1 mg per hour, or torsemide 3 mg per hour can be more efficacious than intermittent bolus doses in patients with severe heart failure or renal insufficiency. Even higher doses have been recommended, 0.25 to 1 mg per kilogram per hour for furosemide, 0.1 mg per kilogram per hour for bumetanide, and 5 to 20 mg per hour for torsemide. An aggressive protocol of a 100 mg IV bolus of furosemide followed by continuous IV infusion at a rate of 20 to 40 mg per hour, which is doubled every 12 to 24 hours in unresponsive patients, to a maximal infusion rate of 160 mg per hour to attain a diuresis rate of 100 ml per hour or greater has been described. In some instances, switching from one loop diuretic to another can overcome the problem. For example, torsemide or bumetanide might work when furosemide fails because of more reliable absorption. If this maneuver fails, a combination of diuretics can be tried. The most effective regimens combine drugs that work at two different parts of the tubule. For example, a loop diuretic is used with metolazone, which blocks sodium reabsorption in the distal tubule. Various thiazide diuretics, including chlorthalidone, chlorothiazide, and hydrochlorothiazide, have been reported to effectively enhance diuresis when combined with a loop diuretic. Triple therapy regimens of metolazone, a loop diuretic, and an aldosterone antagonist are used to optimize diuresis and electrolyte control. Most clinicians choose a combination of metolazone plus furosemide or bumetanide. A wide range of metolazone dosages has been investigated. Typically, a low dose of metolazone, dosed at 2.5 to 5 mg, is first added to the furosemide therapy. Metolazone can be given intermittently, that is 2 to 3 times per week or as needed, to relieve congestion. The longer duration of action for metolazone can cause a greater than predicted diuresis and electrolyte loss when combined with a loop diuretic. Thus, careful monitoring of weight, urine output, BP, BUN, potassium, magnesium and serum creatinine is required. Because no parenteral form of metolazone exists, chlorothiazide, at a dose of 500 to 1000 mg once or twice daily, is an alternative to the thiazide diuretic that can be given intravenously. Although JAJ's furosemide dose could be increased, metolazone 2.5 mg daily was added. JAJ may also require additional doses of potassium supplementation to avoid hyperkalemia with the addition of metolazone. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 293.